Welcome to Healthcare Rounds. I'm John Marchica, CEO of Darwin Research Group. Today, I'm joined by Dr. David Shulkin, a physician, health system leader, and former Undersecretary for Health under President Obama and former Secretary of the Department of Veterans Affairs under President. Dr. Shulkin has led some of the nation's largest and most complex healthcare organizations, from academic medical centers to the VA's massive integrated delivery network. And he's been a prominent voice on innovation, healthcare modernization, patient access, and the leadership challenges facing our industry. Dr. Shulkin, or shall I say Mr. Secretary, welcome back to Healthcare Rounds. It's an honor to have you here.
Great to be here. Thanks, John.
So before we dive in, I went back and I looked. The last time that we talked here, was right before COVID hit. And so this is back in 2020. So it's been about 5 years and a lot has happened since then. And before we get into the questions, I thought it'd just be helpful to update me and our audience on what you've been focused on, what you've been working on.
I continue to stay focused on things that largely help veterans to improve the system that I've come to believe very strongly in. That is having a sustainable and strong Department of Veteran Affairs, which is part of our national security apparatus. And it's important, I think, for our country to understand why we have such a department like this and why it's important to keep it a modern and sustainable system. And I continue to do things that I think are helpful for healthcare in general. I've spent my career focused on things that help populations of health, particularly the underserved populations, and systemic improvements. And if there's anything that's clear about our current situation that we find ourselves in, where we've just gone through a government shutdown and still have as a large focus of political activity, whether we continue the subsidies in the Affordable Care Act, it all involves around the fact that increasingly our system of care is unaffordable. And there are going to be probably more people, not less people, next year without any insurance. And so to me, the message is that we need to find better ways of delivering healthcare. We probably need a systemic and comprehensive look at how our system operates, new reform proposals. And if anything is clear to me in what we see in Washington, is that neither the Republicans or the Democrats are putting on the table any type of comprehensive systemic reform. In fact, we're spending our time really arguing about what I call the band-aids of the system, these subsidies, rather than the real policy decisions that are going to impact all Americans.
Well, we're going to get to those policy decisions and policy questions, at least I hope. And maybe a good way to start is, you've talked about our system being under stress. You've talked about really misalignment. There's sort of a structural misalignment. And so if we were to think about it in those terms, what is, in your view, is driving so much of this dysfunction? And we'll get to the policy questions in a second, but what do you think is driving that?
I do think that it is the structural issues of our system, in that part of what makes the American system innovative and being able to rapidly take in new ideas and the entrepreneurial spirit of the American industrial system is part of the problem that makes it so challenging to deliver a uniform set of healthcare products to Americans, and that is that we are extremely fragmented. The part of the healthcare system that are providers, the doctors and hospitals and long-term care facilities, all have one type of reimbursement and incentive system. The payers, the managed care companies, have another incentive system. Government has a different incentive system. And then you get into pharmaceutical manufacturers that have a different incentive system. All of the middleware people and the services companies and the technology companies, with healthcare now almost approaching 20% of the gross national product. There are a lot of different industries involved in delivering healthcare now. Everybody has a different incentive system, and that means that we're very, very fragmented in the way that healthcare works, healthcare is delivered. But if you try to put a new policy decision in place and everybody looks at the world somewhat differently, that's what makes it so challenging to get any one new idea or solution that sticks, because everybody's looking at it through their own perspective, which makes sense. And that, if anything, puts additional pressure on government, because government, in my view, is really the only one that can get everybody aligned and everybody on the same page by not only introducing policies that make sense, but really introducing a payment system that makes sense for everybody.
So is that sort of the main issue? I mean, if you look at it, if we say that government can be the maybe the only player that can solve some of these problems, but we don't have to go back as far as Johnson, but let's just say Clinton, right? The Clinton administration and the attempts at healthcare reform, and then Obamacare, and in my view, at least, it doesn't seem like today. You said it earlier. It's, do we pay for these? Do we continue paying for these subsidies? Right? Very micro, narrowly focused, rather than the larger picture. Is that because we have so many different people involved and with all of these misaligned incentives, that it becomes really nearly impossible for somebody to have the political will to tackle all of it at one time? Oh, there's a lot in that question, but
Well, yeah, yeah. Look, I think what does ring true to me is that the last time that government took a real systematic approach to reform was back in 2009 with the introduction of Obamacare. That means that the thinking that went behind a policy implemented or law implemented in 2009 really is probably dating back to 2006 to 2008. And, when you think about what's changed in healthcare since 2006 to 2008 to 2025, 2026, we're almost in, a lot has happened. The country has changed a lot. And it certainly, to me, seems time that we're long overdue for a new look at that type of systematic reform. And we've learned a lot about what works and what doesn't during that last 15 years or so as well. Now, whether there is the political will to do this, I think the answer clearly has been no. That it's easier to pick on an issue that you can frame with a soundbite, whether it's good or bad, and whether you want to support it or not support it. But healthcare is not simple as you know it, and it is going to require that willingness to recognize that just continuing along the lines we're doing is only going to delay the ultimate pain that future generations are going to feel. And you can just take a look at whether the Medicare Trust Fund is going to be sustainable. The answer is no. Government calculates a date that it's going to be insolvent all the time. Um, I think that we got very close to insolvency actually during COVID, because the fund is generated almost solely off of employer taxes. And so when you see unemployment rates go up, the trust fund gets shortened. But, I think that we're now seeing that type of concern with the Medicaid population, and, the work eligibility requirements and other issues are going to take people off of the Medicaid role, and that's going to transfer them into the uninsured role. And now that we're seeing commercial premiums for many individuals and small businesses going up 60, 70, 100%, that's going to make that unaffordable. And so it's very clear to me that we can't just continue to pass the buck or put the band-aids on the system. The affordable care subsidies, which most Americans don't understand what that is, and I don't blame them. It's very confusing. But we're talking about that really is addressing subsidization of 20 million Americans in a country that's almost 400 million Americans. So, even if there is bipartisan agreement to continue those, which, in the absence of any other solution, I don't see a way that that doesn't happen. But it's a minority of people that that's going to help. It's really when people realize that these commercial premiums are becoming unaffordable, that it's going to affect many, many Americans that have never really had to face this issue of affordability before.
I'm having a meeting this afternoon with our COO to talk about our health insurance for next year, and it's not looking good. I mean,
No,
we're still offering it, but the numbers are way up. So maybe this is a bit of a thought experiment, but when I think about a lot of the policy conversations, and this goes back to when I went back to school, so back in that 05, 07 timeframe that you were talking about, the things that were generating what became the Affordable Care Act and how different it is now. It seems to me that a lot of, not all, but a lot of the reform has been around payments, ACOs, bundled payments, really trying to get at the disincentives or misaligned incentives around payments. But if we were to think about it, it just seems like it's a massive problem. But if we were to think about, well, what's sort of a minimum viable product, right? And then maybe we have to set aside a little bit of the politics. But if there could be one step forward into getting a better alignment of incentives, what do you think that could be? Or where does your mind go when you think about like a product, like minimum viable product?
yeah. Well, look. First of all, I'm gonna challenge you just a little bit on the issue of that. A lot of work has been done around payments. I would say that what you've described with ACOs, with bundling, with other value-based models that have been introduced both at the government and the commercial level is still nibbling around the margins. When you're running a business and you look at where 5 or 10% of your revenue is coming from or how you're being paid, but 90% still remains a traditional unit-based system of payment. While you can philosophically support a lot of these initiatives or see them as a diversification strategy, they don't become central to how you organize and run your systems of care. And so I would say that those are more marginal, and I'm not trying to, say that they're not important and that they're not good strategies, but they are more marginal strategies. And just one of the things I'll mention before really answering your question about where I think we need to be moving is, we are seeing CMS now introducing a model January 1st called the team model, which is what's of interest to me is it's a mandatory model of value-based care. And this is a first, really, that I see, which is where CMS has sent letters to 774 hospitals saying, congratulations, you're now in this mandatory program where you're responsible as the hospital for the next 30 days of care payments wherever they go outside the hospital included, for some pretty major procedures like cardiac and bowel procedures and spinal procedures. And, up to 20% of the hospital's revenue comes from these types of procedures in general. So they're really signaling that they're getting serious about this. And, while 20% is still a minority, it's not the 90% that remains in fee for service, but it's 80%. It is something that I think the industry should understand that there are people in Washington, policymakers, who believe we've got to start accelerating and forcing this issue. Now, do I think that these models that put the financial responsibility on the hospitals or the ACOs, which are often supported by health systems and hospitals in general, do I think that that's the answer? No, I don't think it's the answer. I think it's a step towards learning how to manage care differently. But I think the true answer is that you need to move towards a population based budgeting of healthcare dollars. Now, what people that are listening to this need to understand is I'm not taking a political position here. Okay. I don't do politics. Okay. Probably the reason why I'm the last cabinet member to get 100-0 confirmation from the Senate, because I just don't do politics. So, but I have come to believe, because of my own experience of running hospitals the way that I have in the private sector and then running the VA, that the system needs to look more like the VA. And that doesn't mean it needs to be run by government the way that VA is. But by that, I mean that care should be paid for to take care of a population of patients. And that's the way that we should be paying for healthcare, not by units of care delivered. And so if you were to divide the country into certain regions and you create a healthcare budget that needs to deliver financial resources to payers, providers, device companies, pharmaceutical companies, technology companies, all with the same metric, and that is improving the health of that population of patients, keeping them out of the hospitals, doing preventative care, doing screenings, addressing ideal chronic care illness management, addressing behavioral health care integration with physical issues. Then I think you're getting to a system that begins to make sense, that can be affordable for everybody, that can drive the best outcomes. Now, what some people are going to say is, boy, that sounds a lot like socialized medicine, you know, and we don't do that here in America. Well, I would say
Yes, we
maybe
do.
that's why, well, yeah, not only do we do some of that,
Right.
but maybe that's why every other country in the world has some type of socialized approach towards healthcare, except for the United States. And as we know, our outcomes are not nearly as good as many of these countries. Our costs are way off from where these countries are. And we don't have to, as Americans, do things the way that other countries do it. We don't have to put in place strict anti entrepreneurial or anti industry approaches to this, but you do need to adopt some basic principles. And those principles would be caring for a population, aligning the financial incentives. It would include every citizen get and be mandated to have access to health care so that there's not uninsured people. It would create a requirement that there be portability of health insurance so that as somebody might choose to get their government or their population based approach from one company, if they move to another payer, that has to go with them so that you take away this, short-term thinking that happens in American healthcare systems. It would have to include interoperability and portability of data so that you don't have this problem of one provider doesn't know what another provider is doing. So this is what I mean by learning and reapproaching a comprehensive and systematic approach towards the way that we deliver healthcare.
So I think you're going to tell me no, but I'm going to ask, is this sort of building on the Maryland model, where you have sort of a a fixed budget for the state of Maryland, and it's increased over time about what is covered under that, or are you talking about something more comprehensive than that?
I don't want to represent myself as knowledgeable about everything in healthcare. Okay. And that's why I think, you know, we're going to need those that have the experience and think the best to get together in an organized approach to do this. But my understanding of the Maryland experiment or the Maryland system of payment is essentially a rate setting program. It is capping prices. And I do not think that is the right approach. Now, I understand why Maryland has done that. And I understand there are some real issues that they're trying to address to control costs. But what they have not been able to do, and this is not to blame the government of Maryland for this, they've not been able to align the financial incentives among all the various players that I've mentioned. They've not been able to move this away from unit based pricing to outcomes based pricing and improving the population health of their communities. And so, if anything, I think when I talk to my colleagues in Maryland hospitals, they feel somewhat restricted by this. So, this goes back to the concept of you have a three-legged stool in healthcare, which is quality, cost, and access. And if you focus on one of them, in this case, Maryland has focused on cost, you can actually negatively impact access and quality. And so, while I admire their willingness to tackle at least one of those legs, I think you really need to think about this as all three legs together, else you end up with unintended consequences.
So it's not the exact same thing, but what you're speaking to is maybe maybe different legs of the stool, but it's like a triple aim or a quintuple aim or
Yeah.
whatever, where you're trying to do all these things simultaneously instead of one thing at a time. But I want to get back to um, this question of a minimal viable product, because
Yes.
you've got to start somewhere, right? And what you're talking, I could say I probably in principle agree with most of what you're saying, but you got to start somewhere, and that's a massive undertaking. How could we incrementally, again, we got to set the politics aside and just and assume that when the time is ready for the political will for whatever, for any of these things to happen, but how could you, instead of like you said, um, the new, I call it like a super bundle, that's out now, is tackling much more around costs and getting at quality and all of that. But how would you think about maybe a minimum viable approach that might have a pretty big impact?
Well, first of all, I think the problem that I see with bundles and some of these what I call pilot or incremental approaches, even if they're, significant national programs, is that they give the financial accountability to one party, whether the bundle is held by the hospital or whether the risk is held by the payer. And, that just doesn't address this fragmentation of different incentives in the system. So I turn out my bias after, doing this for many, many years is I am not an incrementalist. So I do not believe you can fix things by doing incremental strategies. I am much more of a person who says you have to have a moonshot, you have to have your big idea, and you've got to move forward with that. And again, whether you're a Obamacare person or not, and lots of problems with that system. So I could line up on either side of this. At least they went and tried to do something. And their issue that they were trying to fix was access to care, right? They wanted to make sure that every American had a chance to have access. So, what I think you need to do, and that's why I believe this needs to be led by government, um, this needs to be a big bang approach saying that starting in XY year, we're going to have a different system of care. Now, if you want to make sure that you test it out, then you have to do it in a region, a geographic region rather than nationally. But I don't believe you can start picking off 10%, 20%, 25% of somebody's business and say, take us seriously. And that's what I call the incremental approach.
So more like, well, could you do this in the state? Maybe not today. Could you do this in the state of New Jersey, for example? If you said 20 in the state of New Jersey in 2035, we're going to have this system. I'm putting a long time. Maybe that's too long. And by 2030, we're going to have these certain things in place to allow for enough time. Could you do it at a state level or several
The,
states?
the, Theoretically, you could, but imagine, and this is the irony of watching today what's happening. Um, the problem with doing it in a state, unless you're a state that every company thinks that they need to participate in, think about the emission issue with cars, right? Where you do this by state, okay? Probably only California could have gotten away with having their own requirement. If Rhode Island tried to do that, GM and Ford and everybody else would have said, guess what? You're not buying your cars in Rhode Island anymore. You better get them in, Pennsylvania and drive them to Rhode Island. So, what's happened with the Affordable Care Act and with the exchanges, we've seen the for-profit managed care companies pull out of all the markets that aren't profitable. I mean, I can't imagine a provider in a state saying, hey, I'm sorry, we don't like the reimbursement. We're going to stop offering services to patients. But the managed care companies got away with that. They just pulled out of those marketplaces. And so if you did it in New Jersey, I think the fear of the politicians and the people who live in New Jersey is, are any companies going to want to play with that? So you almost have to, when I talk about the power of government, it's the power of mandating. So if you had a way of saying everybody has to play in New Jersey under these new rules, yeah, that could work. If it was New Jersey alone and companies could just say, we're going to sit this one out and we're going to see how it works, then I don't think it works.
Yeah. Well, I want to get back to the VA model. What can back to this incrementalism, I guess, at some level, or minimum viable product. What can we learn from the good in the VA system? We've already said it's the largest integrated delivery network in the country, right? What can realizing that it's going to take a while to get to what you're talking about, but today, what lessons can we learn? Can the Northwells and the RWJ Barnabases of the world can we learn from the VA and implement today?
When I went into VA, I thought, um, at the prime of my career running private hospitals like the Northwells and others around, and just wait till I get to the VA. I'm going to show them how healthcare is run and show them how we do it in the private sector. In fact, when I got there, it was exactly the opposite. I learned things in the VA that I believe everybody who's running private hospitals should be doing instead. And that the VA approach to caring for populations is actually superior to the way that we're doing it in the private sector. And that's not to say that there aren't phenomenal things that the private sector is doing that the VA shouldn't be doing. I think that this is a bilateral learning relationship, but I don't think enough people understand what happens in the VA. And let me just dumb it down by saying, look, When I was secretary, I'd go before Congress and I would say, I'm going to be caring for 10 million of our veterans, and I need this amount of money from you, Congress, to be able to do that. Once I would get that from them, then as secretary, I would decide how that money's being spent. And what's different from the private sector is I didn't have to ask the question, well, what am I going to be paid for? What are the managed care companies actually willing to pay for? So if I wanted to deliver behavioral health in the same setting as primary care, I was able to do that. I didn't have to ask for reimbursement codes for that. If I wanted to provide peer support to people going through really tough issues, we could do that. If we wanted to pay for caregivers in the home and support our caregivers, we could do that rather than waiting until people had to get institutionalized or readmitted to hospitals. But there aren't private sector codes for that. If we wanted to provide service dogs to people with PTSD, we could do that too. If we wanted to take our veterans in competitive sport events like adaptive skiing or the wheelchair games that actually I found to be more impactful than putting them on antidepressants and other types of things, we could do that. So it was a very freeing experience. That's number one. Number two, the biggest single clinical intervention that I found incredible in the VA, the power of the VA versus what we would find in the private sector is in the private sector, you generally wait until the patient comes to you. They get sick and end up in your emergency room, in your surgery centers, or in your hospitals, and they come and they ask for help. At the VA, we could do proactive outreach. We would go out and find veterans who had hepatitis C and treat them with the new antivirals that cured their hepatitis C rather than waiting until they developed cirrhosis and liver disease and needed a liver transplant. That type of proactive population health approach was so powerful, in my opinion, and such the right way to be improving the health of communities. And we replicated that in behavioral health and other areas. And by the way, the VA could be doing much more of that than they are now. But you need to have leaders who believe in that strategy. But I think that's exactly what private healthcare sectors, hospitals and health systems should be doing, and payers should be doing. But look, I'm not blaming them because I was in their roles and I know you can't do things if you're not getting paid for it. And I don't know of any third party reimbursement codes that are going to pay for that today.
So is it, as you know, and my company here, we study health systems. Um, and one of the first things that we look at in the 400 odd systems that we're paying attention to are their pop health programs, right? And how they're focused on population health. And one of the things, and I'm just curious if you agree with me on this, one of the things that I think frustrates, I hate to keep using Northwell, but I know it's at least in your part of the country. One of the things that might frustrate a system like that is to say, well, we don't really have, to your point, control over the payment side of things, right? That's not, or somebody could come into our system, come into one of our clinics, and then they're off at New York Presbyterian or something for other services. So do you need to have that kind of comprehensive, Kaiser model, Geisinger kind of model for this to work? In other words, have everything all in one when you're talking about focusing on populations. And I know we're getting away from or the geographic, orientation that you were talking about, but is that part of the problem?
I don't think you need it all under one roof. And I think that's a common misunderstanding. I think that you do need an aligned incentive and payment system to do that. But I think it could absolutely embrace the diversity and the innovation that we see in the healthcare ecosystem in America and not look towards sort of dumbing down the system by having it all controlled by under one under one envelope or, one ultimate organization. So I don't think we need to do this the way that Canada has or others. I think we can take the best of the diversity and the innovative nature of American healthcare. But if you pay everybody the same way with a common objective, I think you can make a lot of progress.
Yeah, because obviously, I think that's what people are, always kind of get concerned about, or they talk about, well, this is going to stifle innovation, and I agree with
Yeah.
that. I'm an entrepreneur at some level, and I think that we need to be free to invent and do all have all
Well,
of these other things.
I, I I think that what we're seeing right now play out in the pharmaceutical industry should be instructive for the rest of healthcare. The president and the administration has focused on pricing, right? They've taken one of those legs of the stool, affordability, and they've said drugs are too expensive. I think we all agree with that. And they said, so here's how we're going to deal with it. We're going to pay them less. We want to pay them what's called most favored nation pricing based upon an index from other industrial countries. What the industry argues is that if you pay us that much less, you're just going to kill American innovation. I happen to agree with them. It would be a disaster to simply decrease our pricing without anything else. It's the three-legged stool. You're going to hurt quality. You're going to hurt, access. Okay. Or I'm sorry, maybe not access. You're going to certainly hurt the innovation and new discovery in the pharmaceutical industry. So instead of focusing just on price, what would you focus on? Well, what are pharmaceuticals supposed to do? They're supposed to change the health condition. They're supposed to improve outcomes. They're supposed to, by controlling a condition, maybe decrease the total cost of care by decreasing other, things like hospitalizations and unnecessary procedures. So, why the industry has been so slow to recognize that they need a different pricing model is somewhat of, a question to me, and understanding you don't want to play the price only game. And frankly, that's where the rest of healthcare is going to head. It's ultimately going to be price setting back to the Nixon era. A lot of people don't remember that. But price setting is going to be a disaster for the industry. Instead, we need to evolve to a value based system that's based on the outcomes that we're trying to achieve.
I think it comes back because this is something that we've studied a lot, and I've studied this issue
Mm-hmm.
in pharma a lot. And I think the problem comes in when, let's take a money back guarantee, for example. The drug doesn't work, you get a rebate, you get your money back. I mean, in its absolute simplest form. I have a drug for cholesterol. It says it's going to lower it to be in safe range. Doesn't work. You get your money back. And then the question is, well, who gets their money back? Does the patient who put down the copay on the medication? Does the health system where somebody saw them? Is it the insurance company, maybe Blue Cross, where that person? So it goes back to the misalignment question. In fact, we literally have just been testing this and been out there surveying, doing interviews, talking to people about specifically value-based contracting in pharma. And the complexity and the variety of payers and reimbursement has not so much pharma, it has the institutions themselves throwing their hands up and saying, this is way too complicated, just lower the price. Then it goes back to that price question, right? But that doesn't solve all of the issues. So I guess what I'm saying, Dr. Shulkin, is I agree with you, but the problem comes in that I've seen is in the implementation and why a lot of these, with rare examples, so the really expensive drugs, the $2 million, whatever, for spinal SMA,
Yeah.
right? That it makes sense. Small patient population, easily identifiable. But when you talk about cholesterol, heart failure, diabetes, these massive areas, it becomes challenging to align those payments and those incentives in a value-based way.
I don't see it as challenging. I, I think we have all the components that are necessary. If you have a drug that can significantly reduce cardiac and stroke risk, and you decide to only pay for the drug, but you don't take into consideration all of the total costs of the system related to caring for patients who have had myocardial infarctions and strokes and vascular disease, then you can't really assign a true value to that drug. But if you looked at this as a global budget, then it may make more sense that you want more people on that drug, and you may have less cost in other parts of your system if that drug is doing what it should be doing. People take the drug, that is, and it has the effect it should. And so that's where I've said, look, we need to go towards a global budgeting so that these types of decisions can be made appropriately. Now, I don't think it takes away the incentive for new companies to come out with better ways of managing cardiovascular risk. In fact, it only adds to the incentive. But if you start paying pennies for a drug that costs dollars to develop, who's going to develop that next drug?
Yeah, well, and I think I think it goes back to what you're saying about maybe it's a regional approach or however it needs to be addressed. Because again, I know these pharma companies. I know they have health outcomes teams that try to make the total cost of care arguments, that try to, do these things. And, whether it's in the execution but it often falls up because I 100% agree with you that if you could capture that and view the expense of that drug in the total context of what it's actually doing,
What?
it'd be wonderful.
Well, John, look, and I don't think that we disagree here. What I'm trying to say is that we actually can do this. We there's no missing piece other than maybe that political will that you're talking about. And look, I know the president. He and I have talked a lot about drug pricing, and I think he cares. He wants to make drugs more affordable. Okay. Again, not a political endorsement. I'm just saying I've had these discussions. I believe that's where he's coming from.
Said it publicly many times. I agree with you.
Yes.
Yeah,
Right.
sure.
Now, I think you can't fault a real estate developer for not understanding the complexity of this healthcare system and how drugs are priced and what they do. So I think he's getting bad advice. And I think he's been given advice saying, focus on the price. And I think the advice should have been focus on the value. Okay. And this administration in particular, with this past year that we've all gone through, they're not afraid of putting out bold ideas. So imagine had he gotten the right advice, or at least the advice I think he should have been gotten. And instead of coming out with most favored nation pricing, he came out with value-based pricing. You could see a whole different story. Now the industry would be scrambling to adapt to that and all that, but guess what? They could, and it would be better for them. It would be better for all Americans, quite frankly, and probably people across the world, because as you know, what the pharmaceutical companies, many of them are doing in response to this type of focus in the US is they're raising prices in Europe and other places, only making it more difficult for people across the world to get access to medication. So this is not the right policy. It doesn't mean it's not coming from the right place. As I said, I think he wants to make these medicines unaffordable. He thinks the pricing is unfair, but There's a better way to do it. And it's actually really possible to do. There's nothing preventing us from doing it but that political will.
Well, on that note, as always, Dr. Shulkin, it's so fascinating talking about these issues with you, especially since you've been at that policy level, not just in the private sector, and love to continue the conversation, have you back. I'll throw my hat in the ring. If you ever pull together a group of people and you need a researcher from Scottsdale to kind of throw his weight into it, I'm happy to, because these issues, obviously, they fascinate me. And
Yes.
but before we go, I've started doing this little lightning round to wrap up the pod. So quick responses. I've got 5 of these. Quick responses, a sentence or a couple of words, and we'll go through this. You ready?
I'm ready.
All right.
I hope I win something at the end.
Unfortunately, not.
No
You
prizes?
win. You get to go.
Okay.
Have lunch or whatever, whatever your next part of your day is. First one is your most overhyped technology today.
Boy, I know I should have a quick answer, but look, it's got to be AI, only because every company in the world has changed their name to an AI company, and I just don't think they're all going to turn out to be as transformative as they're promising.
Most underappreciated innovation or technology in the last decade.
I I think it still has to be virtual care. What happened in the pandemic with everybody using it and then everybody reverting back away from it once the pandemic ended. It's a head scratcher to me why people don't see the value in it.
We talked a little bit about this, so I'm going to ask for a short answer. A lesson from the VA that private health systems still haven't learned.
I think it is, as I mentioned before, about the ability to do proactive outreach to their communities.
One book that every healthcare leader should read.
That's too easy. It shouldn't be this hard to serve your country, the book I wrote.
and which I read. It was a while ago, which I read. It was a wonderful book. And finally, a mentor who's influenced your leadership.
It's funny. I just last week went to a dedication of a building on the University of Pennsylvania campus that's being named after that mentor, Bill Kelly. He was my first CEO of the University of Pennsylvania, who I worked for 10 years, and had a very fundamental influence on me because he was a big idea thinker and had a vision and just drove towards that.
Excellent. Well, Dr. David Shulkin, thank you so much for taking time, and I hope you come back. It's been a pleasure as always. Thanks again.
Thank you. Enjoyed it. Thank you.
And that's it. That'll do it for another episode of Healthcare Rounds. Please make sure to rate and review if you like this episode. And we will see you next round.